Madam, shall we start?
Yes,
Soma, we start at 8, 5 past 8. Actually, always you wait for people to join till
Okay.
another 34 seconds or something.
Please start.
Okay. Good evening, everyone. Welcome to this new webinar series of restarting with the pediatric neurology subsection of the Indian Academy of Neurology. Myself and Dr. Mini Sridharan are there to just to initiate the thing, and we will be having Dr. Jai Shankar Kaushik and Dr. Somaya Somundaram as the coordinators, and we have a senior expert faculty, Dr. Shyam, who is heading the movement disorder clinic, and Sri Chitra. So we'll have two early career researchers presenting their cases, one from AIMS Jodhpur under the mentorship of Dr. Lokesh Saini, and the other one from AIMS Guwahati under the mentorship of Dr. Kaushik. Dr. Kaushik and Soumya, you take over first. Mini, can you just say hi to everyone, and then Soumya and Kaushik will take over.
Good evening,
Mini?
good evening, respected members. Dr. Kaushik and Soumya Sundaram can now take over and carry on with the proceedings.
Good evening, everyone. This is a great opportunity, and I thank Shefali ma'am and Dr. Mini for this opportunity given to me and Dr. Soumya to conduct this series of case presentation. So this forum is basically meant to introduce a few cases from the pediatric neurology, and it is designed in such a beautiful form by Shefali ma'am and Mini ma'am that an adult neurologist will supervise, and he will act as a mentor, and his inputs will also come. So it's an integrative kind of a form in which our learning will happen. So for the first case presentation, I invite Dr. Lokesh Saini. Dr. Lokesh Saini and his student, Dr. Lokesh Saini, is an associate professor, and he has done pediatric neurology, and both of us have done pediatric neurology under the guidance of Dr. Shefali Gulati madam. I invite Dr. Lokesh Saini and his team from AIMS Guwahati, AIMS Jodhpur to present their presentation. And I invite Dr. Ashwini Chitiala from AIMS Jodhpur to present her first case under the mentorship of Dr. Lokesh Saini. Dr. Lokesh, can you give your words?
Yes, sir. Just now how I am joined. There was a technical problem. Sorry, sir.
Yeah. Hi, Lokesh. Thank you.
Good evening, everyone, sir. Yes, sir.
You can introduce your student, and the student can start her presentation.
Yeah. So, Dr. Ashwini, who is a pediatric neurology fellow at AIMS Jodhpur, she'll be presenting a case where we got to the diagnosis seeing at the gate. So that is what we want to highlight. The child has an interesting presentation, and which she will present.
Share over here.
Go to the slideshow.
Second, ma'am.
On the menu bar, you can see the slideshow of your PowerPoint. You just put it on the slideshow mode, this screen. Your screen is visible, but your PowerPoint is still in editing mode. Yeah. No.
1 second, ma'am.
Yeah.
My slides visible, ma'am?
Yes, perfectly.
Um, Good evening, everyone. Today I'm going to present one interesting case, which is gait has a clue to the diagnosis. I'm Dr. Ashwini Chittiala. I'm doing my Pediatric Neurology Fellowship from AIIMS Jodhpur. My moderator is Dr. Lokesh Saini sir, Associate Professor, AIIMS Jodhpur. So coming to the case, 5-year-old male child, Lakshman Ram from Nagaur, Rajasthan, came with the chief complaints of intermittent involuntary body movements for the last 1.5 years of age, and frequent falls with gait abnormality noticed once the child started walking. According to the parents, the child attained developmental milestones till 1.5 year of age, followed by after the onset of independent walking, the parents have noticed that there is something abnormal with the gait and the child was not walking normally, and there are some abnormal involuntary body movements which involving both upper limbs and lower limbs. The semiology includes there are some slow twisting repetitive movements from distal to the proximum, which are more in the lower limbs compared to the upper limbs, which making the child fall. These movements are persistent throughout the baseline with episodic worsening when the child is when the child was playing or running or exaggerated during exertion. So currently, these movements begin to affect the child, including the walking and routine play, particularly during the physical exertion. Along with the involuntary body movement, the child also had abnormal gait. The gait involved the bilateral lower limbs. Here you can see the child is having abnormal gait in the form of twisting of bilateral lower limb, which are crisscrossing each other. And this gait abnormality is present throughout the year. However, the crossing of the gait becomes more marked when the child start running or when the child start playing, lead to the frequent falls. The child was able to get up immediately after each episode. Over the time, this has progressively interfered with the child's ambulation and daily activities. So there is no negative history of any altered sensorium, or there is no history of any behavioral issues or seizures, or there is no history of any cranial nerve deficit or focal weakness. There is no history of any bladder or bowel disturbances, or there is no regression of previously attained milestones. And there is no, in etiological history, there is no history of any jaundice or perinatal insult, or no history of any visual complaints, or no history of any diurnal variation. And there is no history of any loss of consciousness or episodic unresponsiveness, or no similar complaints in the family, or there is no history of any drug intake. And perinatal developmental history and family history was normal. So based on approach to mixed movement disorder, based on the age of onset, our child had symptoms in less than 1.5 year of age. So we kept this as possibilities.
Can I intervene just? No, well, I am not aware of this pattern of this discussion in this forum. So is it like, are we expected to discuss the history after the history part, have a list of differentials and then go to the examination, or you want to finish everything and then have a clinical approach? Generally, in case discussions, what we do is we discuss history first and then go to examination. But I do not know what is the pattern being followed here. That's why I'm asking.
Sir, based on clinical history, I have kept some possibilities. Again,
sir,
I have
sir, first we will finish the case discussion, and then there will be 10 minutes for the discussion part.
Okay.
In the letter. So.
Okay, fine.
Based on the approach to mixed movement disorder, and the onset of symptoms was in less than 2 years, so I have kept this thing as possibilities. So one of the possibilities is dyskinetic CP, but however the child didn't have history of jaundice during the neonatal period. And the second possibility is early onset dopa responsive dystonias, but the onset is very early in this child and there are no diurnal variations. And the third possibility is PCAN, but however the child didn't have other symptoms. And the fourth possibility is hereditary spastic paraplegia and arginase deficiency, because the gait is looking crisscross. However, in our child, there is even the upper limb involvement. And the sixth and seventh possibility is PKD versus GLUT1 deficiency, because the symptoms are intermittent and intermittent, and it is mixed movement disorder. And eighth possibility is neurotransmitter defect, because the onset is early. I want to keep this as differential. So in our case, there is history of mixed movement disorder along with gait abnormality, and the symptoms are very intermittent. Even though they are present throughout the baseline, they will exaggerate during the exertion. So I want to narrow the differentials to 4. So my first possibility will be the GLUT1 deficiency, because the child is having intermittent symptoms which are worsening by exertion. However, the negative thing is there is no history of any seizure, and there is no history of any cognitive decline. My second possibility is PKD, because the symptoms are intermittent and they are exaggerated during exertion. But the negative point is the child never attained the normal state in baseline. And my third possibility is PCAN, because the child is having mixed movement disorder and the age of onset. However, the symptoms are persist intermittent. And the fourth possibility is early primary dystonias. The first possibility is because the child is having mixed movement disorder. The negative is there are no diurnal variations. So on examination, you can see the child is conscious, alert, and listening to the grandfather commands. And you can see that the movements are very slow. The upper limb movements are very slow, twisting, repeating pattern, flowing, and they are unpredictable in quality. And this is more involving the lower limb predominantly compared to the upper limb, and the distal movements are more compared to the proximal movements. And these are the home videos we have received from the father when he came to the OPD visit for the first time, which helped us to lead the diagnosis. So the first video, you can see the child is walking, but there is some crisscrossing while walking. So the movement disorder is more in the lower limbs compared to the upper limbs. There is complete crisscrossing when he was while walking. When we have seen the second video, so the child is crisscrossing while walking. And when he was trying to run, he fallen down. And this is the third video which we taken at the time of our visit. At the time of our visit, where you can see the child still had crisscrossing pattern on while walking. So all the three videos have similar pattern, that is crisscrossing of gait. So this is the point which gave us one clue. So in other examination, there is no cranial nerve deficit, no upgaze palsy, tone is normal, and there are no contractions, and the power is 5/5 with DTR 1+. And there are no oromotor dyskinesias and no cerebellar signs, and other systems within normal limits. So what is happening here? So frequent falls with preserved strength means it is not motor weakness, it is a motor control weakness, that is basal ganglia. So we want to approach, we did some basic investigations like bedside tests like fundus. In fundus, there is no retinitis pigmentosus or there is no cherry red spot, and even optal there is no KF ring, and the Bera there is no sensory neural hearing loss. And we did simple blood investigation like hemogram, which came to the normal, and metabolic workup like lactate, ketone, ammonia, everything came to be normal. LFT and KFTs are normal, and EEG is also normal. We advised MRI, which was done on the same day itself, to rule out some simple causes like basal ganglia or GP signal pathologies, so the MRI came to be the normal, ruling out the structural causes of any basal ganglia. So what is happening here? The gait is crisscrossing and the twisting movements along with the flow irregular movements, and the symptoms are worsening with exertion. Is this a spastic gait? No, it is not spastic gait, because the tone is normal at the rest, and it is variable sometimes, but there are no contractures. So it is not spastic. So here we ruled out arginous plus hereditary spastic paraplegia. So what can be the gait? The gait can be the hyperkinetic gait because of the chorea and dystonia. So the involvement is basal ganglia. So workup till now is negative. So our differentials are narrowed to GLUT1 deficiency versus PKD. So keeping possibility of GLUT1 greater than PKD, we have sent genetics directly. which showed positive. Based on the home videos, we found that the child is having crisscross gait. So even in the genetics form, we have written as crisscross gait, and we kept the possibility as GLUT1 deficiency, and it came to be as positive SLC2A1 exon 5 and 10, which is pathogenic mutation, autosomal dominant. So not only this, we have reviewed the literature previously, the one of the neurology journal where the similar pattern of gait was seen, and even we have reported one case previous report where the similar pattern of gait we have noticed. That's why we have suspected crisscross gait and GLUT1 deficiency. So we have directly sent genetics than doing the invasive investigations. So this is the neurology journal where the child is having similar pattern of gait. When he is walking, there is complete crisscross of gait, and which is making him unstable during walking. So in the same study, they enrolled 3 cases. All had the onset before in childhood onset. Currently, they are adults, and all them had crisscross gait, and all CSF were done only in one patient. Genetics was done in all the 3 children, which came to the positive for SLC2A1. So what's happening here? Here, crisscross gait in GLUT1 deficiency. Maybe it is because of the GLUT1 channel defect. This GLUT1 channel defect is defective. Transporter is defective on the blood-brain barrier, where the initial failure mechanism occurs at the capillary level. Here, the capillary level GLUT1 channel will be defective. So the glucose will not enter into the astrocyte. So there is no formation of lactate, and the glycolysis pathway is not done. So the lactate will not enter into the neuron. So there is no entry into the Krebs cycle. So there is failure of astrocyte neuronal energy circuit, leading to global energy failure. Even though the neuron have receptor of GLUT3 receptor, but it can't utilize glucose because of primary substrate failure. So at the end, the glucose is low in the CSF. So there is global energy failure, which leads to the seizures because of the neuronal hyperexcitability and developmental movement disorders and developmental delays. So we can treat the child. We have treated the child with ketogenic diet, because the alternative fuel is ketones, which acts to the MCT1 channel. So this is the child video after 1 month of treatment. So you can see here the child is able to walk. The movements are comparatively reduced compared to the previous videos, and you can see the child is able to walk. There is less crisscrossing, there is less falls, and the child is walking comfortably. However, there is still dystonia present in the upper limbs. So why this crisscross gait happens? So in GLUT1 deficiency, there is severe chronic neuroglycopenia. Because of the low energy brain glucose levels, the high energy regions will be affected, like basal ganglia, which cause basal ganglia dysfunction. If the basal ganglia dysfunction occurs, there will be lower body chorea dyskinesia that occur intermittently, and this become exaggerated when the child runs, or when the child plays, or when the child is fasting, or under the conditions of stress like fever. So this result in the crisscross gait. So our case highlights for frequent falls with preserved strength, then suggests motor control issue rather than motor issue, and attention to the gait pattern can narrow differentials towards the treatable causes, and home video assessment can provide valuable clues to pick the diagnosis and avoid unnecessary investigations and invasive investigations. So briefing about GLUT1 deficiency, it is a neurometabolic disorder causing by monoallelic or biallelic pathogenic variant. It is due to the SLC2A1 gene, which encodes a GLUT1 transporter, which is present in the blood-brain barrier. When it is defective, it will cause brain energy failure. Neurological symptoms includes epilepsy, which include absence epilepsy, infantile onset epilepsy, and movement disorder spectrum, which includes chorea, dystonia, ataxia, and cognitive impairment and motor regression. The classical phenotype is developed DEE. So I want to end my slides with this. Despite few case reports, the crisscross gait has reaffirmed as specific to the GLUT1 deficiency. It is a rare but a treatable medical condition, and early starting of ketogenic diet can improve the outcome, and home videos can really be helpful. Thank you.
Thank you, Dr. Ashwini, for a wonderful presentation. It was very, very crisp. Dr. Lokesh, your comments.
So, sir, like the message Ashwini already gave, that we should give due importance to home videos, as well as if we already know that this type of gait occurs in some particular disorder, try to verify with this. Like, even if you are able to verify, it is good if you can take help of some movement disorder specialist also. So I do take help sometimes. I send sometimes to like higher authorities in movement disorders. So, but if you are narrowed down to like, okay, because I published a crisscross gait 2 years back, so I was very sure, okay, this is probably GLUT1, and this child turned out to be GLUT1, and this is what the purpose of showing this case to this audience, because like a peculiar gait and not a common gait, but like crisscrossing is happening and spasticity is absent at rest, think about GLUT1, especially if there is movement disorder. Thank you.
Thank you, Dr. Lokesh. Dr. Ashwini, there are few questions in the chat box. Any history in this child of paroxysmal head-eye movements in infancy? Dr. Ashwini, can you respond?
Actually, we got the history of some abnormal uprolling of eyes, but it is not associated with any tonic-clonic movements. But however, we didn't find any video. But when we admitted,
So they were like, we asked this history after we got this report, because we want to be sure, is there any history of oculogyric movements in childhood. So they were also not sure. Parents were not reporting it. But after repeated asking, they were telling there was something like this happening in early childhood, but they were not sure. So we have not presented in this case.
Okay. Thank you. Just one more question which the audience have had before we hand over to Dr. Shyam's comments. In the history, were you thinking of anything specific? Because one of the comments says that primary dystonias are of so many different types. So based on the history, I saw that in the fourth differential, you had kept a primary dystonia. So was there any primary dystonia particularly in your mind?
Yes, sir.
You want to answer? Yes,
Actually, there was one case which presented a dyskinetic CP to our OPD. That is GCH1 deficiency, where the child presented as dyskinetic CP, and the onset of symptoms were started at less than 2 years. So that's why I have kept that.
So early onset severe autosomal recessive variants. So they present sometimes GCH1. So that is what we want to mean here, not the Sigawa disease, classical Sigawa disease.
Correct. Thank you. Dr. Shyam, sir, for your valuable comments, sir. Dr. Shyam, sir.
Yeah. Thank you. It was a very interesting case, I would say, and I think she presented very well, worked up very well. A few comments from an adult movement disorders specialist perspective. One is it is regarding the examinations. Like in the videos, I was seeing that the child was always walking. So it is when we examine systematically, it is always better that we make the child sit and then watch the child and maybe get a video at that time again. Because when somebody is constantly walking, it is difficult to find out whether there's a chorea. So for assessing a chorea, you have to make the child sit somewhere and then just look at the child whether movements are happening. So in that video, what I could see obviously was a generalized dystonia, which was affecting the upper as well as lower limbs. the characteristic twisting movement. I was unable to appreciate any definite chorea, but if you make the child stand and then watch the child, probably there's a chorea also. So, and to say paroxysmal kinesogenic dyskinesia or any sort of paroxysmal movement disorder, interictally, that is in between the events, the movements should not be there generally. And PKD is a specific situation in which it happens when the child gets up. The child gets up, suddenly he develops a choreo or the ptotic movement, and in maybe 20 to 30 seconds, it subsides. So it will not be continual like this. So I think PKD doesn't come in the differential of this child because it was continually present. And then another comment is regarding the primary dystonias. Actually, the term primary dystonia is a little confusing, and now the Movement Disorder Society is urging to avoid its use because primary dystonia indicates that indicates the etiology. What do we mean by primary dystonia? We mean those dystonic conditions in which there is a genetic defect which causes only dystonia. So you are looking at the etiology actually. Etiologically, there should be a genetic condition which presents only as dystonia. But rather, at the time of presentation, we will not be able to know that genetic etiology. So the current trend is to differentiate dystonias into isolated dystonias in which you have only dystonia as in this child, and combined dystonias in which dystonia is combined with chorea or myoclonus or other involuntary movements or pyramidal signs, cerebellar signs, cognitive dysfunction, etc. So you have to differentiate whether it's a dystonia which is isolated, that is only dystonia, or combined. And then you have to look at the phenomenological features of dystonia, whether it is focal, multifocal, segmental, which part is more affected. Based on that, you can have a list of differentials. So when a child presents with an dystonia alone, as I believe this child had only dystonia and maybe a little chorea, which I'm not very sure. So when somebody presents with dystonia alone, you have to think of those genetic conditions which can manifest as isolated dystonias or the so-called primary dystonias as per the old terminology. Primary dystonia means there will not be any other abnormality. It will be only dystonia. So the DYT1 or DYT TOR1I, the TOR1I gene mutations is one of the most common and well-recognized cause of primary dystonia. In fact, there are certain other genes like the TAP1, or there are so many other genes described, and each of them have their phenomenological features. Generally, primary dystonias or dystonia due to DYT1 mutations in children present with lower limb dystonia like this. They may have gait problems, and people may even mistake it as cerebral palsy because it generally starts in the lower limb. They will have gait abnormalities and they may have some little burst reflexes. So it may be mistaken for cerebral palsy often. So that's about the primary dystonias, the discussion about the primary dystonias which we had. I think otherwise this was a well worked up case. This crisscross gait is well described, but often it is spoken about, but very rarely only we see. And I was very happy to see this case. There are so many other gait patterns described in dystonias. The dromedary gait, that's a camel-like gait in the DYT1, or the cockwack gait, which is seen in the hypermagnesium. There are different gait patterns described. So, okay.
Thank you very much, sir, for your valuable comments. So we worked up this, like we examined this case at rest also, but because of the theme of the presentation, gait and walking, so and time constraint, we only included the videos which the child is walking. And we agree with all your comments, sir. Thank you, sir.
Thank
you. Dr. Lokesh, thank you. Can you just give your last comment? One of the question was, can GLUT1 deficiency associated crisscross gait have associated epilepsy and developmental regression?
So they have. I have the case which I have reported, which it has epilepsy also, very bad epilepsy.
So in this child, EEG was done.
Yeah, that is why EEG was done.
No, in this child, in the index case that you.
Yeah, it was done. It was done. It was normal in this.
Okay. So thank you, Dr. Lokesh, and thank you, Dr. Ashwini, and wonderful comments from Dr. Sham. I think it was wonderful presentation overall. I think I hand over this to Dr. Soumya for the second half.
It was an excellent presentation. Now, I thank Dr. Lokesh Saini and his team for doing a wonderful job, and also Shamsa for his expert inputs. Now I invite Dr. Shayshankar Kaushik, who is a professor and additional professor and head from AIMS Guwahati. Please take over this session for this second case. And Dr. Akhila Das is the presenter. Please introduce your student and go on with the second case discussion. And we have 18 minutes for the case presentation and 10 minutes for discussion. Thank you.
Thank you, Soumya ma'am. And it's a proud privilege to bring my greetings from Northeast India. And I invite Dr. Akhila Das, who is pursuing DM in Pediatric Neurology at AIMS Guwahati. She has done her MD from PGI Chandigarh, and I invite Dr. Akhila for her presentation. Can you share your slides,
Thank you,
Dr.
sir. Yes, sir. Shall I start?
Yes, please start.
Thank you, sir. Good evening, everyone. I will be presenting a case of a child who struggled to write. So we have a case of Master R, 4-year, 2-month-old boy, hailed from Silchar, Assam, who initially presented to our center on 25th of October 2025 with complaints of sudden jerks of upper limbs for the last 3 months. So he was a developmentally normal child with a normal perinatal history who was in his usual state of health 3 months before presentation, who developed sudden lightning jerks on writing or any purposeful movements involving the proximal part of upper limb, which were non-rhythmic and erratic, and this movement disappeared at rest and sleep. The burden of the movements progressively increased over the course of 3 months, and parents also noticed that there was a twisting of hands while writing, which noticed over the next 2 months. This caused difficulty in writing and caused him to have an illegible handwriting. There was no urge or any suppressibility for this movement, and there was no diurnal variation and no involvement of lower limbs which was causing any falls, nor there were any tremors. Sorry, there is a problem with the presentation. There was no history of any difficulty in vision or hearing. The child did not have any history suggestive of cranial nerve involvement. There was no history of any convulsions or behavioral changes or obsessions or compulsions. There was no history of any paucity of limb movements, and nor there were any history of jerky eye movements, swaying while walking, or any dance-like movements of limbs, or any slow writing movements of the distal part of limbs. There was no history of any rash or muscle cramps reported by the parents as well. The child was first born to a non-consanguineous marriage, and there was history of sudden jerks of upper limbs in the father with onset around 6 years of age and remitted in third decade of life. This was not affecting activity of daily living in the father, and there was no history of any alcohol dependency in the father. Birth history and immunization and developmental history were normal, and he belonged to the upper class according to modified Kupuswamy classification. On examination, vitals were normal, and general physical examination and anthropometry were in normal limit. On systemic examination, on central nervous system examination, higher mental function and cranial nerve examination was normal. On motor examination, gait, bulk, tone, and power were normal, and DTS were elicitable in all 4 limbs and were normal, and bilateral plantars were flexor. So on examination, as we can see, there is the hyperkinetic, arrhythmic, very fast, ill-sustained and paroxysmal movement involving segmental regions of proximal upper limb and faciocervical region, predominantly involving the proximal upper limb. This was medium in amplitude and was present in action only, and was not present during the during rest. This was also if we concentrate properly, we can also see that this was also the child was also having in between there was intermittent twisting of wrist while writing. This twisting movements were twisting movements are actually limited to the distal part of the hand. Other system examination was normal. So on database, we have a 4-year-old boy who was developmentally normal with twisting movements and sudden jerks of hand while writing and other purposeful movements, and a positive family history in father having similar jerks. So on examination, there was dystonia limited to distal part of the hand and myoclonus of proximal upper limb, face and cervical region. So the possibilities we kept considering the dystonia myoclonus symptoms. First possibility we kept was dystonia myoclonus syndrome, that is DYT11, and the points favoring that the child was having dystonia and myoclonus on skillful movements, and this was limited to the upper part of the body, and there was a similar history in the father. We could not find any points against this disease. And other possibilities we considered include autosomal dominant GTP cyclohydrolase deficiency. And points favoring include dystonia and myoclonus on skillful movements and similar history in the father. However, this is one of the rarest presentation of GTP cyclohydrolase deficiency, though reported. It can present with just myoclonus and dystonia. There was no diurnal variation. Also, GTP cyclohydrolase deficiency will present with more involvement of the lower limb. This was not the case, not seen in this case. Another two other dystonia we considered was KCD T17 variant, which can also present with dystonia myoclonus. But in this disease, the dystonia is more predominant than the myoclonus, and there can be laryngeal involvement, which was not seen in the index case. ADC Wi-Fi associated dystonia also can present with dystonia and myoclonus. However, this usually present more with poriform movements or any facial involvement and gait disturbance, which was not seen in our index case. Other secondary causes of isolated vitamin E deficiency, which can also present with dystonia and myoclonus, which is again an isolate, seen only in isolated case reports, but it is a treatable cause. That's why we considered this possibility, and it is an autosomal recessive condition associated with defect in tocopherol transfer protein. But the points against was this was an infrequent presentation. Also, there was no ataxia and vibration proprioception was intact in this case. Tyrosine hydroxylase can also present with dystonia myoclonus. Again, trunk was not involved and the child was developmentally normal. So these were the points against. So we reviewed the approach to dystonia and myoclonus, childhood onset dystonia and myoclonus. And in our case, this was after reviewing the history and examination, this was more considered to be a presumed genetic cause with no chorea or ataxia, with the body distribution limited to the craniocervical and upper limb with a positive family history. So we decided to test this child for genetic testing, considering a possibility of SGCE mutation. Other investigation we did was EEG, awake EEG, which showed no IEDs were appreciated, and MRI brain was normal. So we went ahead with whole exome sequencing, and it was sent. And meanwhile, the child was given a trial of Syndopa at 1 mg per kg per day. So whole exome sequencing was suggestive of SGCE variant, pathogenic variant, autosomal dominant and heterozygous, and which was consistent with the DYT11 myoclonic dystonia syndrome. So for the child, we started the child initially on zonisamide at 2 mg per kg per day and was gradually raised to 3 mg per kg per day. And significant improvement was reported by the parents. As you can see, the child has started writing, and most of his handwriting is legible now. And the myoclonic jerks, which was present previously during writing, has decreased to a greater extent. However, on subsequent visit, the child was also noticed to have psychiatric manifestation like specific phobia, as the parents described that he was having excessive fear while taking lift or while traveling through a flight. So DYT11 is a myoclonus dystonia syndrome is a genetic childhood onset movement disorder which is characterized by the presence of dystonia and myoclonic jerks, which is caused by mutation in the epsilon sarcoglycan gene on chromosome 7q21. So the sarcoglycan protein is present in the same sarcoglycan protein that is present in the muscle. Similar protein is present in the brain and is widely expressed in the neurons, and mainly it is expressed in the midbrain monoaminergic neurons, cerebellar Purkinje fibers, also other brain regions including hippocampus and cortex. So the pathophysiology underlying DYT11 is still in development, but a recent review speculated that a loss of epsilon sarcoglycan can induce the neuronal membrane damage, leading to a calcium accumulation. So the hypothesis is that it can cause dysfunction in the cerebellum, brainstem, basal ganglia, thalamocortical pathways, and altogether can lead to an abnormal neural network, which will result in the clinical phenomenology. So the age of onset is usually 2 to 6 years, which was consistent with the index case. Most common presentation is usually a lightning-like myoclonic jerks, which is reported as lightning-like in most of the case reports and series, and predominantly involving the proximal upper limb. But it can also occur in any other body part, and myoclonus can be observed either as an isolated presentation or in association with a mild to moderate dystonia. In 15 to 30% of cases, isolated dystonia can also be an initial presentation. And most common form of dystonia is usually a writer's cramp, as was seen in our patient, or a cervical dystonia as well. Lower limb dystonias are very rare, and especially rare in early age of onset. So amelioration of motor system with alcohol is a classical feature which is attributed to the defect in GABAergic pathway. So as this is a graphic representation of the distribution of myoclonus and dystonia. So as described earlier, it is more towards the upper body part. Both the dystonia and myoclonus are involving the upper body part. So the positive predictors for a SGCE mutation include myoclonus as the prominent motor sign, which can or cannot be associated with a dystonia, predominantly involving the upper body part. And usually the onset will be in the first 2 decades, especially in the first 1 decade, with a positive family history and psychiatric comorbidities, all of which were present in our child. And negative predictors include a truncal dystonia and a coexistence of action myoclonus in the same body region. So our child had action myoclonus in the same limb, but the myoclonus was in the proximal upper limb, and dystonia was more concentrated towards the distal part of the upper limb. So psychiatric symptomatology is part of the clinical spectrum of SGCE myoclonus dystonia. A recent multi-center study investigated the psychiatric symptomatology, and they found that 65% of the manifesting carriers can have at least one psychiatric diagnosis, most of which included specific phobias or social phobia, followed by alcoholic dependence and obsessive compulsive disorder. So in our child, this is the diagnostic criteria proposed by Rosie in 2018. So in our child, we could find that he had all the major criteria, including the myoclonus isolated or predominating over the dystonia, prominence of the motor manifestation in the upper body, absence of truncal dystonia, positive family history, and onset before age of 18 years. So, the exclusionary criteria include any other neurological manifestation in addition to myoclonus dystonia, an abnormal MRI or neurophysiological finding not supporting the diagnosis. So it was considered that it is inherited via an autosomal dominant manner, but the recent studies have found that the disease inherits in a maternally imprinted manner. So if there is a mutated gene that is inherited from the father, then the mutation carriers will manifest symptoms with complete penetrance. So the treatment, there are currently no targeted therapies available directed to the biological hallmark of MDS. Medical and surgical measures are there, of which the first line that is now currently used includes zonisamide. So in a recent randomized control study in 23 patients, it was found that zonisamide significantly improved both action myoclonus and myoclonus related functional disability, and significantly improving the dystonia as well compared to placebo, and it was well tolerated. So this is the first line option intervention now for the early in the disease course, as well as in a later stage of the disease in mild to moderate forms, or patients with severe forms as well, who are not eligible for deep brain stimulation. Other anti-seizure medications, anticholinergics like trihexyphenidyl, dopaminergic agents like tetrabenazine, pymoside, and botulinum toxin has also been tried with limited success in this disease. Pallidal deep brain stimulus is well tolerated and effective and should be considered in patients with the severe forms of myoclonus and dystonia. It is effective on both the myoclonus and dystonia with a sustained benefit observed over years. So a pre and post interventional study done in 10 patients, it was found that DBS of globus pallidus syndrome mitigated long-term disability, potentially enhancing the academic, social, and professional prospects. So the key points include in a child presenting with dystonia myoclonus with upper body distribution with a positive family history, think of DYT11. Psychiatric manifestations are part of around, it is seen in around 65% of patients and should be addressed. And first line treatment with zonisamide has shown significant improvement in studies and case series. And resistant and severe cases, DBS is an option. Thanks everyone. Thanks to the medicine. The child is currently able to write with some legible handwriting.
Thank you, Dr. Akila. It was an excellent presentation. And you have highlighted the very diagnostic points in this particular disease, where there is upper body dystonia plus myoclonus, when you suspect DYT11 due to SGC mutation. And it has got a autosomal dominant inheritance pattern. Dr. Kaushik, do you have any comments regarding this particular case?
Thank you, Dr. Soumya. So I think it was a very interesting case. Rather, it was initially thought like a tic disorder when the child came to us. So that was the thought process that came. But I felt that no, totally not. It was like an evident dystonia myoclonus which the child was having. One of the question which the audience, Dr. Apurva has asked is very, very valid, that the phobia it is very difficult to, completely differentiate that the phobia could not be because of zonisamide. And that is very, very well known that zonisamide could have also caused, but these phobias were present even before we started the zonisamide. But that phobia were not so manifest when the child started, but after we started zonisamide, the parents rather came back. They wanted to take an opinion, second opinion, so they went by flight to another place, and the mother faced such a severe phobia on the plane that she really felt really cramped. So even our child psychiatrist, madam, has also seen the child, and we are right now keeping the child under follow-up. We have not started clonazepam, but yes, I also thought that clonazepam could have been a good choice. I think it will be great to hear Dr. Shyam sir on this. His comments will be very useful.
Yeah, thank you. It was again a very interesting case and a very good case with a lot of learning points. So when just like what we discussed for the previous case, it is always better to classify movement disorders as whether it is isolated or combined. So myoclonus dystonia is a classical combined movement disorder. So you have dystonia, along with that you have myoclonus. So when there is say a second manifestation other than dystonia or other manifestations other than dystonia, either movement disorder manifestations or other neurological manifestations, you call it a combined dystonia. So when somebody presents with a dystonia and you see a myoclonus also, so it's a combined dystonia, and the subsyndromic, the next syndromic level is the myoclonus dystonia. So myoclonus dystonia, the most common gene mutation is, as we found in this child, it is the SGC mutation, or it is the most characteristic or the most well-known mutation. But there are so many other genes also. For example, the ADCY5 gene, which classically presents as a mixed movement disorder. It can present as chorea, myoclonus dystonia, or a mixture of any of these movement disorders. And it is now recognized as one of the causes for myoclonus dystonia. And then there are other genes like the KCTD17, which are all recently described. So, and we also have to know that myoclonus dystonia can be acquired. For example, somebody who is having a hypoxic insult, major hypoxic brain injury, the dystonia is a common manifestation, and they can have Lance-Adams myoclonus. So, a hypoxic injury is a cause for a secondary or an acquired myoclonus dystonia. And the myoclonus dystonia is a very characteristic in that its dystonia as well as myoclonus will respond to deep brain stimulation. The reason is the myoclonus in myoclonus dystonia is a subcortical myoclonus. We know that myoclonus is classified into cortical myoclonus, which is probably the most common cause of myoclonus, which we see in all the storage disorders or many of these progressive myoclonic epilepsies, or cortical subcortical myoclonus, which is seen in the primary generalized epilepsies. And in myoclonus dystonia, it's a subcortical myoclonus. Subcortical myoclonus means the cortex is not involved. It is an interaction between the brainstem and basal ganglia structures, which lead to myoclonus in myoclonus dystonia. So, DBS, because of this specific pathophysiological aspect, DBS gives improvement to both myoclonus as well as dystonia in patients with myoclonus dystonia. And medical treatment options include zonisamide and maybe clonazepam or levetiracetam. Zonisamide is probably the one which gives the best results.
Thank you, sir. Now we have another question. Can we think of AVED without spastic ataxia since it is a Friedreich's ataxia mimic? Dr. Kaushik would like to answer that?
I think Dr. Akila will be better to answer.
Okay, Dr. Akila.
What is the question, sir? What is the question?
Can we think of AVED without spastic ataxia since it is a Friedreich's ataxia mimic? I think
it doesn't have ataxia, no? It is
okay.
dystonia plus myoclonus.
I'm not sure if this question was for the last child.
Okay.
Maybe.
Might be. Correct.
Maybe. Okay.
Correct. And Professor Vinay Goyal has suggested that they have published a case of YY1 mutation presenting like DYT1. So there is another etiology associated with probably myoclonus dystonia syndromes. Then ANO3 mutation. Somebody has suggested whether it could be ANO3 mutation.
ANO3 mutations only occur at a little older age, and maybe it is a dystonia syndrome, and sometimes it can present as myoclonus dystonia also. But the age of onset is generally older, maybe in 20s or late teens, and it predominantly affects the craniocervical region, cervical dystonia, dystonic tremor, etc. So the phenomenology doesn't classically fit with that of ANO3 mutations, but of course it is one of the causes for unusual causes for myoclonus dystonia.
Then would you consider doing CSF neurotransmitter studies in this child pending whole exome sequencing? Is there any role of sending serum prolactin?
Actually, I will agree with Akbar, sir. I think this was one of the thought process that often comes once the MRI is normal in children with movement disorder, but we didn't send, we actually sent the whole exome. But it's a valid suggestion. The thought process can definitely be entertained.
But we actually seldom send neurotransmitters at present since the genetic testing have come recently. When it is negative, yes, obviously we used to.
Yes. Rather, we go to the invasive ones on a later date now.
Yeah. Correct. Then to the expert.
Serum prolactin is a good suggestion. It was definitely in my thought, but we didn't send it. I agree.
Okay. Then would it be important to identify which is the predominant movement disorder in a case of mixed movement disorder in order to have a clinical approach, whether it is myoclonus dystonia or dystonia myoclonus?
Yes, definitely. Definitely, we have to find out what is the key movement disorder. Many of these patients with dystonia also can have some jerks. So, for example, those with cervical dystonia due to other mutations or without any proven genetic mutations, they also can have some jerky component, but that is not the predominant. The predominant movement will be the dystonia. So, when somebody has got very prominent myoclonus also associated with dystonia, then you classify it as a myoclonus dystonia syndrome. So, all the mixed movement disorders, we have to look at what is the predominant movement disorder and what are the other associated movement disorders. That definitely helps in listing the differentials.
Okay, thank you. Now over to Dr. Kaushik, and as well as final words from Dr. Shefali, Gulati ma'am, as well as Mini madam.
I think we are all dot on time. Last 3 minutes for Shifali ma'am and Mini ma'am for their final comments.
I think Wendeley fully presented wonderful cases, and it was good learning exercise, and we are on time. And we welcome you for all these monthly sessions. And this is the slot you keep waiting for every month now. We'll get you something very different each time. And in case anybody wants something specific, they can send us the mail for the same. Mini, can you share the official mail of the Peds Neurology subsection of IN? Also, besides the comments. Besides your comments.
In
Besides your comments.
WhatsApp group, I'll share. Is that okay?
Sure. I mean, and the young ones presented well and on time. That was good, right? And Dr. Shyam, his inputs have been very, very, very useful. Yeah. Dr. Mini, it's up to you to sign off.
Thank you. Thank you, Dr. Kaushik, Dr. Lokesh, and his team, and their team, and also Dr. Shyam for your expert comments, and thank you, Dr. Soumya, also. Thank you for the participation, audience.
Thank you, everyone.
Thank
you.
you,
both.
Thank you.
Thank you,
Good
everyone.
night.
So,
See you next month. Same time.
okay.
Thank you, Asmita.
Thank you.
Thank you.
We'll sign
Asmita,
out.
thank you, beta. Thank you.
Thank you, ma'am.
Bye. Good night.